Welcome to Frank Buckley Interviews. This time on the program, a difficult subject, but one we will all face in our lives. We're talking about death, and more specifically about dying and how, when, and under what conditions we will die. How much control do we really have about how we leave this life? How much control should we have? How can we die with dignity? Like I said, a difficult subject this time. It's one that author and journalist Katie Engelhart explores in her new book, The Inevitable: Dispatches on the Right to Die. And I'm delighted to welcome Katie Engelhart to the program. Katie, welcome to Frank Buckley Interviews.
Thank you for having me.
Of course. I think it'd be fair to say that most of us want to delay the end for as long as we can. And I also think it's fair to say it's something most of us try not to think about or talk about, but not for you. How did you become introduced to and then interested in this subject of assisted suicide and the right to die?
Well, it started out when I was covering different state and national debates over right to die legislation. So from time to time, an American state will deliberate on whether or not to pass an assisted dying law. And I found the subject interesting, but what I found more interesting was the fact that a lot of Americans are already taking matters into their own hands. They're not waiting for laws to pass in states where they don't exist. They're making plans to end their lives if and when they become so ill that they don't want to continue living. And I was fascinated to learn that just there was an incredible amount of activity going on outside of doctors' offices, outside of legislature offices, outside of polite conversation. And it really convinced me that this is a subject that people want to think about, want to talk about, but don't feel like they have an outlet for.
But was it just a curiosity as a writer and a journalist that initially prompted you, or did something happen in your personal life?
It was more of a journalistic curiosity. But, that said, I've seen normal deaths. We've all seen deaths that occur in hospital settings that are, slow, long, a little confusing, maybe that involve some end-of-life pain, end-of-life delirium. A lot of people, and myself included, have seen older relatives decline in a way that feels sort of out of control, almost like one treatment leads to the next and the next, but choices aren't being made, and really that patients' wishes are never explicitly being interrogated and honored. That's kind of a normal modern death. And I always found it an unsatisfying prospect. And so I was extremely interested as a reporter to meet people who were much more interested in choreographing their final hours if they could, and really deciding in advance how they wanted the very ends of their lives to unfold. This is not completely unprecedented. I mean, we've seen a lot of efforts among patients to take control of their healthcare, and we've seen it in birth. Women choosing how and where they want to deliver and in what context. We've seen it in the management of chronic care. Patients deciding, for instance, that they don't want to pursue treatment because they'd rather be comfortable. This is part of a broader movement that's really unfolded over the last couple of decades.
There was a line in your book that really jumped out at me, and that was that death isn't always poetic. That we have this idea that it's going to end a certain way, but you found that's not really how it often happens.
No, again, I think it's often this drifting. Someone is sick and they go from this treatment to that treatment, and this fails, and the doctor recommends this, and all of a sudden there aren't options, but there are drugs, and never really is there a moment that feels like a choice is being made. And oftentimes, people find deaths to be confusing. They know some kind of pain-relieving drug, some kind of sedative drug was given in a hospital setting, but they don't know exactly when or to what effect, and whether or not that hastened their loved one's death. So I think that deathbed scenes aren't like what we see in the movie, where someone looks up at their family and says, a lovely final phrase, and then closes their eyes and drifts away peacefully. That happens, but it's rare. Yeah. And it's a shame, because I think it's what people expect.
Right. I want to talk to you about some of the people that you profile in the book. One of them is Dr. Lonnie, is it Shavelson or Shavelson?
Mm-hmm. Shavelson.
Shavelson. Dr. Shavelson. Tell us about Dr. Shavelson and his practice.
So Dr. Shavelson set up a boutique practice in the Bay Area shortly after California passed the End of Life Options Act, which legalized physician-assisted death in the state. What Dr. Shavelson found was when the law passed, it didn't necessarily open the floodgates for assisted death like certain critics thought it would. In fact, even though the right to die became legal, it wasn't necessarily accessible to patients. A lot of doctors in the state either opposed physician-assisted death or just didn't want to involve themselves in the process. And that actually meant that when patients were pursuing their legal right for physician assistance, they were coming up against all these hurdles. So Dr. Shavelson started a clinic that specifically dealt with patients who were being turned away or sort of delayed by their traditional medical providers. And through that clinic, he was able to help people who were eligible under the law. So people who were terminally ill and within 6 months of what we might call a natural death. So most people have cancer or some kind of heart condition that has this more predictable trajectory. And in that clinic, Dr. Shavelson helped over 100 patients to die. And he died in most instances with him at their side.
And what was predicted, and you sort of touched upon this in terms of the criticism before the law was passed and what has been the reality. I think it's been 5 years now since the law went into effect. What have we found about how this happens, how often it happens, and whether it's working?
Yeah, so there are a few things that we've learned from California, but we've learned these lessons even more from Oregon, which has had legal physician-assisted death since the 90s. When the laws passed in Oregon, critics worried that there would be this rush of right to die cases, that we'd see fairly healthy people with, cancer, for instance, march into their doctor's office and just demand access to a quick death. And that's really not what has happened. These deaths have remained rare. They account for just a couple of percentages of normal state deaths. And we've also learned a lot more about the people who are choosing these sorts of deaths. So again, critics at the beginning worried, and I think fairly, that we might be paving the way for vulnerable people to be kind of coerced or pushed into these early deaths, either because someone is explicitly coercing them or because they just don't have access to good healthcare, say, or good pain management. And they imagined people who were poor, who were old, who were scared, kind of choosing death over a life that could have been made better. And again, that's not really what we've seen. The data from Oregon and California show that people who choose physician-assisted death are more likely to be white, educated, insured, usually with Medicare, and so presumably receiving, fairly good healthcare access. And most people aren't choosing to die for the reasons that we expected. So I expected, certainly when I started researching this book, that people would want a physician-assisted death if they were in pain and just couldn't bear it and wanted a way out. That's not the reason that patients typically give their doctors. Patients say they want physician-assisted death because they want to maintain dignity, because they want autonomy, so they want to be in control. They choose it when they've lost access to activities that make their lives bearable. So some of these more existential reasons actually coming into play as opposed to purely physical reasons.
And in terms of the mechanics of it, I don't know how to put this, but has it been perfected so that if you are someone who wants to die and has made this with a clear mind and has checked all the boxes, is this something that can be done in a painless sort of way, in the peaceful, poetic way, if you will, that this person might intend?
Yeah, it's a good question, because as Dr. Shavelson and others told me, they don't teach you how to kill people in medical school, and
Right.
They don't design drugs specifically to end patients' lives. And there was a process of physicians having to come up with the right formula of drugs. They started by using a barbiturate that came from Europe, but Europe banned exports of the drug because it was being used in death row cases and death row executions. And later, Americans came up with a kind of cocktail of respiratory and cardiac drugs, which work instead. So yes, doctors have found a way to ensure that patients can die peacefully and relatively quickly, though the time can vary from kind of 20 minutes to a few hours. Now, I should say that the process in the United States is very different from every other country where physician-assisted death is legal. So in Canada, for instance, and in the European countries like the Netherlands, where this is possible, patients almost always get a lethal injection from their doctor. That works very quickly. It's very predictable. It's very reliable. In the United States, there's a requirement that patients self-administer the drugs themselves, which in most cases means that the patient will drink a lethal solution. And this adds some variability to the process. So it can take longer. It can take hours because of the way someone's digestive system works. And you can imagine there are sometimes difficulties given a patient's physical limitations. So if someone, say, can't move her hands because she has a brain tumor, or is too weak to hold a cup of barbiturate because he has ALS. So again, there are these difficulties that are unique to the American process.
Yeah. All right. We are going to take a short break. As I said, a difficult subject. When we get back, I'm going to ask Katie Engelhart more about some of the people who have made it their life's work to help others to end their lives early. Welcome back to Frank Buckley Interviews, continuing our conversation with author and journalist Katie Engelhart. She's written the new book, The Inevitable: Dispatches on the Right to Die. Katie, I want to talk to you about some of the people who you focus on in the book. One of them is Avril Henry. She was not terminally ill, yet she wanted to die. Talk to us about her case.
Avril Henry was a retired professor living in England. She taught art history. A brilliant woman, had lived, by her own description, a wonderful and rich life. She was in her 80s, and though she wasn't dying of anything in particular, she was suffering from what we might euphemistically call old age. So she had this collection of symptoms which she found together to be unbearable. Everything from some deafness, some issues with vision, difficulties with mobility, neuropathy in her feet, all things that are part of a kind of typical aging profile, but that she found difficult to bear. And what Avril decided was that she wanted to end her life before she declined further. And she felt that she'd lived a completed life and could sort of satisfactorily end it at that moment. Now, Avril was not eligible to die under any British law. She wouldn't be eligible to die in a state like Oregon or California where physician-assisted death is legal because, again, she wasn't terminally ill. A doctor wouldn't be able to say that she was going to die within 6 months. And so Avril chose to work with one of several online groups that I profile in my book, which consist of volunteers who help people to end their lives in a peaceful and quick manner, either using different techniques or by obtaining specific drugs. And Avril did end her life at the moment that she wished, again, to avoid a further decline into old age. And she wasn't alone. I met a number of people who talk about not wanting to reach a very advanced age. We consider it this huge success that medicine has been able to extend life, and it is a success. I'm so grateful for it. But for a lot of people, that's going to mean many years, if not decades, of quite extreme disability and illness. And for some people, that's not a desirable outcome.
And yet this idea that we are going to take our own lives earlier than nature intends seems unnatural in some ways. And I just wonder, the people you encountered who chose this route, did they all seem like, again, for lack of a better word, normal? Did they seem, of sound mind, et cetera?
Yeah, I mean, I'm certainly not a doctor and a lawyer. I had no ability to determine someone's medical or legal capacity, but certainly someone like Avril was very certain in what she wanted, and she didn't present as depressed, and in fact vehemently denied that she was depressed. She said she'd had a wonderful life, and for that reason wanted to end when she still felt like she was herself and was sort of experiencing life in the way that she had wanted to. I certainly think it's true that people who choose physician-assisted death or who choose to end their lives in this kind of pre-planned way are people who were used to being in control in life.
Yeah.
You know, they're used to getting what they want. They're used to being able to follow their wishes in this way. Another point I want to pick up on is the use of this word natural, because, you're not the first to say this seems sort of unnatural, but what is a natural death? Most deaths today are not natural. They involve a lot of medication and medical intervention. They often take place in a hospital setting. Often the patient has sort of been out of it for several days or weeks because of heavy sedation. And, we can ask whether we consider that to be a natural death anyway.
Yeah. Katie, your book is not just about the people who want to end their lives early. It's also about people who've made it their career to help other people to commit suicide. For most of us here in America, assisted suicide is synonymous with Jack Kevorkian. How's Dr. Kevorkian regarded now by the people in the Right to Die movement? What is his legacy?
Certainly, when people think of the subject, they think of Kevorkian, who famously in the 90s helped patients to end their lives, many of them in a rusty Volkswagen van that he would park in public places. He was sort of outlandish. He was eventually prosecuted and did spend time in jail. I think a lot of activists today really wince when the name Kevorkian is brought up. He was not a perfect flag bearer for this cause from their perspective. I mean, he acted outside of the law. He acted in a hasty manner. In some cases, it's questionable whether the people he assisted were very sick at all. And so certainly, I think doctors today want to distance themselves from any suggestion that what's happening in assisted death is haphazard or outside of the system. It's very regulated. It's an extremely regulated process. It involves a lot of paperwork, formal waiting periods, witnesses, and so it is really a far cry from what we saw in the 90s.
A word that comes up frequently in your book is dignity. You talked about it a moment ago. Do the people who are seeking dignity in death through this manner, do they find it?
I think some of them do. And I think for others, even just knowing that they have the option makes them feel assured. So there's a good number of people and of patients in every state where this is legal, like Oregon and California, who go through the process to obtain physician assistance, who get the prescription or the doctor's approval, and who choose not to use it at all. And what I've heard from doctors is just that prescription, just the okay, can be a sort of palliative cure in itself, because it lets the patient know if things get bad, if things feel wrong or kind of unmanageable, then they have this option. And so I think for some people, just that comfort is enough.
Yeah. All right. We're going to take one more break. We'll come back with Katie Engelhart, author of the new book, The Inevitable: Dispatches on the Right to Die, when we come back. And we're back with Katie Engelhart, author of The Inevitable: Dispatches on the Right to Die. And Katie, I was wondering, in your coverage of this story, is there one particular person who sticks with you that you think about?
I think quite often about a reporting trip I did to Belgium, which has legal physician-assisted death, but which has eligibility criteria much, much broader than anything we'd see in a state like Oregon or California. So in Belgium, and as in several other countries, people can qualify for an assisted death if they are not physically ill, but are mentally ill. So for instance, if they're suffering from long-term depression or obsessive compulsive disorder, another kind of mental illness. And in the course of my reporting, I ended up connecting with a woman my age, in her early 30s, who had been approved to die after 3 psychiatrists agreed that she was suffering from incurable depression. And, you know, on the one hand, I found this woman to be very intelligent, very sure of what she wanted, convinced that she had tried enough treatments and that she had no reasonable prospect for improvement. On the other hand, it was really hard not just to think, you're so young, is it really possible to say that nothing can work? And this woman ended up taking her life with a doctor's help and her mother present. And, you know, I think about that death often. On the one hand, I think it's reasonable to say, well, mental suffering is real suffering, just like physical suffering. Advocates have been telling that for years, and we're finally recognizing it to be true. On the other hand, you know, there are a lot of difficulties when that come up when the law is extended to this patient population. Nevertheless, Canada, where I'm from, has actually decided to expand its law to include people with mental illnesses. So that will happen next year.
Well, Katie, thank you for what you've written. It's a fascinating book, and obviously something that we'll be discussing for quite some time to come. Thank you very much. The new book, once again, The Inevitable Dispatches on the Right to Die. And thanks to Katie, and thank you for joining us. We hope you'll join us later in the week on the audio podcast.